Hi, everyone. It's nice to see you. If we haven't met before, my name is Dr. Karen Trainer, and I am a veterinary pathologist at Innovative Vet Path. And I'd like to share some interesting findings from a case with you today, and we'll go ahead and get started. So I'm going to pull up this case. This is from a dog by the name of Kasha, and she has some very dramatic lesions that I think um, were just a very interesting combination of findings that I don't think I'd quite seen before. And I thought you might find it interesting as well. So this is Kasha, and she is an 11-year-old female spayed German Shepherd mix. And these, all the clinical photos that you see are provided by Dr. Britta Reynolds. She was the primary care practitioner who is caring for Kasha. And she has a history of being perfectly normal until late August or September, when she reportedly had some sort of GI issue that she wasn't seen for by a vet. But then all of a sudden, her hair started falling out and she became very itchy. And as you can see, the hair loss is pretty universal. It's affecting almost the entire body, and I'll show you some more pictures. There's a little bit of hair left on dorsal midline and a little bit on the face, but otherwise it's almost complete universal hair loss. She was taken to a local ER clinic on September 12th for pain, where she was diagnosed at the time with fever, skin infection, ear infection. She was treated with a mix of drugs, including gabapentin, Clavamox, prednisone, methocarbamol, Zymox, Odic. So she was treated with a number of things. And after that visit to the ER, she was not improving. So then she went to her general practice and was evaluated by the veterinarian there. And on physical exam, they found that all over her body, the entire body was affected, all of her skin. They found all of these, in addition to the really dramatic alopecia, they found these multifocal areas of erythema with yellow crusting. And so that's important to pay attention to, especially the description of the crust being yellow. And then scales, red skin, patchy spots of hair that epilate easily. And all of her paw pads were very hard and thickened. And there was also pitting and oozing edema of the right rear limb. So just another example of the really dramatic hair loss, and then these areas of erythema with some intermittent yellow crusts interspersed. They did radiographs of her thorax and abdomen. Everything appeared normal. Skin scrape from several sites was negative. Good job for doing those skin scrapes. And then next step was biopsy. So they took multiple 6-punch biopsies. I'm so happy. That's a really good size. I would really aim to go 6 or even 8 if you can. And the biopsies were taken from top of the nose, over the right eye, the large pad junction of the left lateral side, left shoulder, left hip, and left hock. Again, I commend the clinician for taking so many skin punches. I think that's really what helped to make this diagnosis, is because they did such a thorough job sampling the skin. So just to let you know, the lab findings, because they've done a CBC Chem, UA, and T4, on the chemistry panel, the albumin was low, slightly low at 2.2. Glucose, interestingly, was low. BUN was normal, and cholesterol was normal. The reason I draw your attention to the fact that the albumin and glucose are low is because these 4 products, albumin, glucose, BUN, and cholesterol, are all produced by the liver. And whenever I see a history of a dog with crusting anywhere, particularly if the paw pads are involved, especially if it's an older dog, if I see any one or multiple of these 4 factors is decreased in output, one thing I do wonder about is hepatocutaneous syndrome or hepatic synthetic failure. So that's something to pay attention to. So they've done an excellent job with the background minimum database. And then on the CBC, This dog, she had a neutrophilic leukocytosis with a left shift and mild lymphopenia. She also had some mild to moderate anemia as well. And then there was trace proteinuria on the urinalysis, and the T4 was slightly low. But it's important to note that at this point, she'd been on prednisone for about a month. So this is just an image showing some of her paw pads and how thick the crusting is on these pads. I would point out that a carpal or a tarsal pad is excellent to biopsy because it's a non-weight bearing pad. So this one would be a really good area to biopsy. But just look how dramatic all of this hyperkeratosis is on the paw pads. There's not a whole lot of differentials that we would have for clinical lesions like this, but certainly hepatocutaneous syndrome in an older dog, pemphigus foliaceus, perhaps nasodigital hyperkeratosis, which can just affect the paw pads or just the nose. So maybe that's not quite the best term. And then there are some other conditions, certainly distemper you think of with hard pad disease. This dog doesn't quite seem to fit that bill. So original biopsy results was hyperkeratosis, orthokeratotic, epidermal and follicular, diffuse, marked with epidermal and follicular hyperplasia, and follicular ectasia and atrophy, lymphoplasmacytic dermatitis, and serocellular crust. So the clinician was a little stumped about where to go next with this case based on these findings. And this is part of why I recommend submitting complicated or unusual derm lesions to a dermatopathologist, someone that really takes a deep and abiding interest in reading these cases. There's actually, I don't disagree really with anything that the original pathologist found. I think they did a very thorough job. I would say that part of the complexity of Dermpath is interpreting everything in the clinical context. And I don't know if the original pathologist had access to the clinical photos, because that may have changed their interpretation. So the dog had not been responding well to treatment. And so the biopsies were submitted for a second opinion because it seemed like there wasn't quite a clear direction of what the next steps were or what the exact cause of this was. And sometimes that is the case. Sometimes we can't get that definitive diagnosis on histopath. So I want to share with you, this is just an example showing, how extensive the hair loss is. Even her tail is affected. It's pretty dramatic. And so I'm going to switch over and go to the histopath. So I'm going to pull up one of the other slides. And this was a very unusual case, and I think I just happened to be lucky with this. I was sent H&E recuts, and so that's something else that may have affected the interpretation, is maybe I had sections or findings that weren't available to the original pathologist on the recut slides. So I just want to take you through those. There's 3 slides. I think this one will be the best. So just to get you oriented, we're looking at haired skin, and we can tell that this specimen here is from the face. And there's a big clue, 2 big clues that help us to figure that out. In part, we see all of this muscle here. This tells us that we're dealing with a biopsy sample either from the face or around the rump area. That's usually where you'll see that muscle and minimal subcutaneous fat. And then the other clue that we have is these gigantic sinus hair follicles. So these are vibrissae or whiskers, and these just happen to be included in the biopsy, and they're just gorgeous. And these are tactile hairs. You can see they're much larger as compared to regular hairs, which is, I guess, a little difficult to use this case as an example since she does have extensive hair loss and alopecia. But we are looking at this gorgeous vascular chamber, this whole complex filled with with erythrocytes within these vascular spaces. And when the hair is moved, that's a signal as part of the sensory receptor. So it's a fascinating bit of anatomy, and we just happen to catch two of them in this section. It has a thick fibrous capsule. Every once in a while, I get one or two of these submitted for biopsy because the vet is concerned about a mass effect. And it is just a normal sinus hair follicle, and they are beautiful. So that is from the face, and this section is probably also from the face. We have some muscle here. And so when we're looking at this, we can see how thick the stratum corneum is, and that there's all this crusting and hyperkeratosis. And just as we saw from the original pathologist findings, it is predominantly orthokeratotic hyperkeratosis. There is a bit of parakeratosis mixed in, but that's really in the minority here. It's not the predominant type of hyperkeratosis. And the reason that's important is because remember one of those differentials that I mentioned we were concerned about before was hepatocutaneous syndrome. And with that, we would expect to see marked parakeratosis, a layer of laminar edema and pallor in the mid portion of the epidermis, and then basal cell hyperplasia. And we're not seeing significant, there is some acanthosis here, but we're not really seeing the laminar edema, and we're not seeing a significant component of parakeratosis. There is some serocellular crust though, and I think that's going to be something that we need to pay attention to. And so we'll do a little bit more snooping in the crusts, because with so much of Dermpath, the answer is in the crust. So we'll keep looking, and we'll take a look up here, and you can almost appreciate that there's an alternating laminar appearance here between the orthokeratosis, serocellular crust, a little more orthokeratosis, a little more serocellular crust, a little bit of parakeratosis dusted in. So what's the most important feature here are these bright pink areas within the serocellular crust. These are very hard to identify, but these are acantholytic keratinocytes. And it's important to note that there's virtually no bacterial growth here. I'm not seeing any large colonies of bacteria on these samples. And that's relevant because that tells me that the number of acantholytic keratinocytes is higher than would be expected with just, say, pustular dermatophytosis or with pyoderma. And so we're not seeing any dermatophytes within the stratum corneum. We could do special stains if needed, but we have pretty good evidence now of pemphigus. So we also have this bit of serocellular crust right here as well. And there are a number of acantholytic keratinocytes tucked in here as well. These were the H&E recuts provided by the lab, so this was the best that I had to work with. But remember also, she had that really dramatic alopecia. So what's going on with that? We're looking, there is some follicular keratosis, which was described. And then the epidermis has almost a slightly papillated appearance. And then there's this mixed dermal inflammation. So let's take a closer look at that and see what's happening. It's a pretty non-specific mix of inflammatory cells. We've got some lymphocytes, we've got some plasma cells, we've got an eosinophil, maybe some neutrophils, we've got some dilated apocrine glands, we've got a touch of hidradenitis in some areas because the inflammation is going into some of the apocrine glands in a few areas. But we're not seeing any epitheliotropism, so that helps us to take off something like epitheliotropic lymphoma. This is all lymphoplasmacytic inflammation. And here we see a nice hair bulb. This is a very nice anagen hair bulb, and we're not seeing any lymphocytic inflammation associated with that. So that tells me that something on the order of alopecia areata is unlikely. I'm also not seeing a lot of inflammation centered on the hair shafts. So something along the lines of pseudopelade, I would not consider that. We see retention of the sebaceous glands. If anything, they might even be a little bit hyperplastic. And so there are occasional hair shafts within lumens, and some of them do look like anagen hairs. Some of them look more like hairless telogen, but it is a bit hard to assess. So let's take a look at a couple more of the sections. So this is from the paw pad. And we know that because we have minimal hair. This is from the edge of the hair and hair edge of the paw pad, because then here's the sebaceous glands and hair follicles. And then this is the fat pad that's associated with the paw. And then the thickened stratum corneum. And we see here on the paw pad, this is all orthokeratotic keratin. So that's more evidence that we can help to rule out hepatocutaneous syndrome, take that off our list of differentials. But then here we have this serocellular crust, and within the crust we have these acantholytic keratinocytes. And they are admittedly very sneaky here, but they're all tucked in with the cellular component. All these brightly eosinophilic round structures. These are our acantholytic keratinocytes. So that's our diagnosis right there. And the paw pads can certainly be affected with pemphigus foliaceus. It's really important to remember that. I know sometimes it's easy to forget that, especially if it's primarily affecting the paw pads in dogs, but that is an important location to check. Unfortunately, I don't know how this sample was embedded, but this is how, this is what I had to work with. But I didn't quite see what I would call true follicular atrophy. These seem more like hairless telogen follicles, maybe a bit of follicular keratosis. But this did not look as atrophic as I would have expected for, say, an endocrine alopecia, because remember that T4 was a little bit low. So we don't know if that's due to the dog having been on prednisone or if that's true hypothyroidism. But this doesn't quite look typical. So what I will share with you, though, is that after we diagnosed her with pemphigus, my leading differential for the alopecia was alopecia areata, telogen effluvium, rather, excuse me, because the hair loss was so sudden, reportedly. And then by the time I got the slides, the H&E recuts for second opinion, and had contacted the clinician with the findings, she told me that that Kasha's hair was already starting to regrow. So that does tell us that telogen effluvium was most likely, and it's probably associated with that previous GI issue that she was never seen for. And what happens is the hair follicles all, there's stress in the body. It can be initiated by high fever, by parturition, lactation, drug reaction, any sort of stress can cause it. Even emotional stress in people can lead to telogen effluvium. So the hair cycle sort of synchronizes. And normally, it's the hair follicles are predominantly in anagen phase, but with this, they all go to telogen, and then the hairs will epilate easily, and they all fall out pretty much at the same time, and it's usually very dramatic. It's very rare to see this on biopsy, so that's part of why I wanted to share it with you, because it was sort of a complex case, almost two different things going on at the same time. And I just thought it was really interesting because I don't think I've ever diagnosed telogen effluvium before. And it really seems to be mostly based on the clinical findings and the clinical history and the photos provided by the clinician. That really helped to set the stage. And so much also depends at what time the skin biopsies are taken after the initial onset of hair loss. So I hope you find this case interesting. Please comment below if you have any feedback or a different interpretation. I'm open to that. Anyway, I really enjoyed sharing Kasha's case with you, and I hope you enjoyed it as well. All right, take care until we see each other again. Bye.